We'll talk about Graves' disease and how we as surgeons address this problem. I think I prepared a talk for 30 minutes and then realized it's 20 minutes, so I'll cut down on some of the slides. And some of what I was planning to say has already been covered by the previous speakers, so that'll make my job easier. Right, so what have we got? So we'll talk about indications for surgery in Graves' disease. I'll go through a case, running through the diagnosis, give you some data about Graves' disease management in Sheffield and in the UK and more generally. We'll talk about whether surgery is the preferred option for relapsed Graves' disease and how it compares with radioiodine. We'll talk about preoperative preparation, controlling hyperthyroidism, how you work with your endocrinologist and get the patients ready for surgery. Vitamin D deficiency has been covered, so I'll probably skip that. Postop issues, again, some of them have been discussed previously, but I'll show you our protocols and patient satisfaction from both surgery and radioiodine. Okay. So essentially, the indications for surgery in hyperthyroidism are as follows on the screen. So you have Graves' disease, poorly controlled on medications, either because they're intolerant to antithyroid drugs, they've not had a good response, or they've had serious side effects like neutropenic sepsis being one of the common ones. Relapsed Graves' disease, so they've had a full course of antithyroid drugs for 6 months, 12 months, 18 months, whatever your endocrinologist prefers. They come back with relapse, and then the endocrinologist has a chat with them about definitive options, either a further course of antithyroid drugs or radioiodine or surgery. And then they come to you for a final discussion as to whether they want to go ahead with surgery. So that's another indication. Toxic nodule and goiter and subclinical hyperthyroidism in conjunction with primary hyperparathyroidism, we'll leave that. That's beyond the scope of this talk. So we'll just focus on Graves' disease. Now, a bit more detail about the indications for surgery in Graves' disease. Now, you do have radioiodine as a really good alternative treatment to surgery, a really good definitive treatment for Graves' disease. And therefore, there are some patients that you might feel are more suitable for surgery and some more suitable for radioiodine, and practice does vary from center to center, depends on the primary endocrinologist in charge of the patient. But what we would consider strong indications for surgery as opposed to radioiodine are patients with severe thyroid eye disease, because the risk of problems with your eye disease is much greater with radioiodine than it is for surgery. Pregnancy and lactation, radioiodine is contraindicated. If you've got a large goiter with maybe some compressive symptoms, then radioiodine isn't going to sort out the goiter. It might reduce the size of the goiter a little bit, but the lump is still there. And obviously, if you do have a nodule, which is indeterminate or suspicious for cancer, in a patient with Graves who's probably had an ultrasound scan that shows a 2-3 centimeter indeterminate nodule, then you go for surgery. And there are some weak indications: patient preference, patients with mild or moderate thyroid eye disease, mild or moderate goiter, patients with young children at home who don't want to stay away from their children for a few weeks after radioiodine, and some patients just don't like the idea of radioiodine for whatever reason. So they might be indications as well. So we'll talk about the first patient, the 35-year-old female referred by our endocrinology colleague. She was treated with carbimazole, tolerated it, went into remission. She's recently relapsed, but now is reasonably well controlled on carbimazole and propranolol. Otherwise, well, she's not had neck surgery before, and she's not had radioiodine ablation before. So yes, she's been labeled as having Graves' disease. But what's the differential, and how do you confirm the diagnosis? Any takers? Anyone wants to put the hand up? And no. Okay, fine. We'll look at all causes of hyperthyroidism, and then I'll talk about the primary differential and why, as surgeons, we need to ensure that the diagnosis is Graves' disease as opposed to something like a toxic nodule. So these are all the causes of hyperthyroidism. The ones that I have underlined are the ones that surgeons would come across, some more commonly than others. But the most important differential in this kind of scenario would be a toxic nodule. So in patients with a toxic nodule, you don't necessarily have to do a total thyroidectomy. They could be well served by a hemithyroidectomy, and therefore it's important to ensure that we've made a distinction between Graves' disease and a toxic nodule when it comes to planning an operation. Okay, so what are the clinical features of somebody with Graves' disease? So diffuse goiter without nodules would be one clue. Thyroid eye disease, almost inevitably it will be Graves as opposed to a toxic nodule or a goiter. I do make sure that they have TSH receptor antibody levels done. Usually the vast majority of patients would have had it done. The endocrinologist would have sorted it out. And if the TSH receptor antibody level is high, then even if they have a nodule and on a technetium scan, that nodule is more active than the rest of the gland, you're better off doing a total thyroidectomy. So TSH receptor antibody positive patient with hyperthyroidism, you can say that is Graves and nothing else, and proceed to planning your operation. A proportion of patients with TSH receptor, a proportion of patients with Graves are antibody negative, right? If that's the case, you make sure you have an ultrasound scan or a technetium scan. Now, in an ultrasound scan, you'll have a diffuse goiter with increased vascularity in Graves. In a toxic nodule, you'll have an obvious nodule and the rest of the gland is suppressed. And a technetium scan can also help you differentiate between Graves and a toxic nodule, right? Why is this important? To plan the right, it's important because you can then plan the right operation. I've got an example in the next slide. So this young female with toxicosis who has been referred with possible Graves with a request for you to do an operation, you find that she's antibody negative. So in this instance, and only in this scenario, do we request a technetium scan. So this is a technetium scan result for this lady, and you find that it's only one side that is hyperactive or hot, and the other side, the other lobe, is suppressed. So essentially what this patient has is a toxic nodule and not Graves, and the operation can be a hemithyroidectomy and not a total thyroidectomy, with the potential that she may not need thyroxine following surgery, and the potential for reduced risk because you've not done a total thyroidectomy. So it is still important. Yes, the patient might have been seen by our medical colleagues, but it's still important to think about, is this really Graves? Could this patient have just a hemithyroidectomy as opposed to a total thyroidectomy before you list these patients? Okay, so a few numbers from our unit. So we had over 650 patients over 5 years. And this will just give you the context or the background so you understand a little bit more about Graves when you're counseling patients for surgery. So the vast majority of patients are very well controlled on antithyroid drug treatment. Only a few are poorly controlled and might be referred to you on an urgent basis saying they've either had side effects with antithyroid drugs or the patient isn't tolerating the drugs very well. Of those that are controlled, you will see that the majority, 80% or so, will go into remission. So these drugs are really effective and do what they're meant to do. Some of them lose control while they're on their 6 months, 12 months, or 18 months regime and might be referred to you at that stage. But the ones that go into remission come off the medications and do well, but about 50% of those who went into remission will have a relapse in the next 5 or 10 years. So when they have a relapse, they go back to the endocrinologist, and they are offered 3 different sort of plans. One is to get them under control again and do an operation. The second is to get them under control and give radioiodine, and the third is to just give them a long course of antithyroid drugs again. Okay, so in our practice, most patients go for either surgery or radioiodine. Very few go for antithyroid drugs, and the distribution is sort of virtually 50%. 50% go for surgery, 50% go for radioiodine. Okay. Right. So let's go back to our patient. So she is confirmed to have Graves' disease on account of raised TSH receptor antibodies. She's keen on definitive treatment. She's a little bit unsure as to whether she should have an operation or whether she should have radioiodine. She's already had a discussion with the endocrinologist, but she wants to come and have a chat with you as well. before making a decision. So then we need to know about both radioiodine and surgery. So we can also discuss the pros and cons of both approaches and guide the patient into making what would be an appropriate decision for her. So what information would we need to help us in our decision making, and what are the pros and cons of surgery versus radioiodine ablation? Right. So there are a number of factors that would influence my recommendation as to whether somebody should have surgery or radioiodine, as would my colleagues. And occasionally we see these patients together. So the patient has the opportunity to ask questions about radioiodine from the endocrinologist and about surgery from me. So you consider these factors. Disease related, do they have thyroid eye disease? Is it severe thyroid eye disease? Do they have a goiter with or without a colon nodule? And are their TRAb levels very high? So these things would push me more towards suggesting surgery as a preferable alternative to radioiodine. Patient-related, pregnancy, lactation, other severe comorbidity that might contraindicate either surgery or radioiodine. Those are important as well. Social factors, young children, fears regarding radioiodine, some would have a lot of anxiety about going under the knife, under having a general anesthetic. So you take into account all of these factors and you talk to the patients, and you have your own perspective, your own perceptions about risks with surgery and radioiodine, and based on local facilities and expertise, you make a decision. Okay, so lots of factors that need to be taken into account. A lot of the times patients will come to you having already discussed this in detail with your endocrinologist, but it certainly helps for you to be aware of these issues. Okay, physicians' perceptions and preferences are, I think, the really important sort of driving force that helps patients choose between surgery and radioiodine. And it does vary quite a bit from one endocrinologist to another, and also from one center to another. So we did a little survey a little while ago now, asking physicians and surgeons of their perceptions of outcomes after surgery or radioiodine. And essentially, we found a huge variation in what endocrinologists and surgeons perceive as the complications of both radioiodine and surgery. So relapse after antithyroid drugs, the perception of relapse rates varied from 10 to 70%. Failure rates of radioiodine varied from 0.9 to 60%. So these are consultant physicians and surgeons. Relapse after first dose radioiodine, again, some thought it was up to 50%, which is not the case. And amongst physicians, and their perceived rates of permanent laryngeal nerve injury and permanent hypoparathyroidism varied hugely as well. So these perceptions will inevitably influence patients' choice. In some ways, it's good to be aware of that. It also helps to have data locally as to what your sort of outcomes are, and then you can help the patient make a choice. Because you have a very good alternative. It's not like cancer surgery, like you've got cancer, you've got to have an operation. It's not at all. You have a very good alternative in the form of radioiodine. And this other slide is also quite interesting. So this shows what endocrinologists specifically would recommend to their patient as to what to have after a relapse of Graves' disease following a full first-round medical treatment. So we give them a scenario and we ask them, what would you use, or what do you think you would suggest or be inclined to suggest? And you find that in Scotland, Omar may or may not be surprised with this data, in Scotland, East Midlands, East Anglia, second-round antithyroid drugs were commonly used, okay? Commonly used, not always used. In Wales particularly, and in West Midlands and Northeast, radioiodine seemed to be the most commonly used modality. And in Yorkshire and Humber, in East Midlands and Southeast outside of London, surgery was the most commonly used modality for relapsed Graves' disease. So it just shows that the practice is extremely variable and varies from region to region within the UK. Okay, so a gist of what are the pros and cons of surgery and radioiodine. So surgery, well, quick acting, negligible failure rates or no failure rates. You're going to treat the hyperthyroidism. You'll make them hypothyroid straight away. It's better in thyroid eye disease, and lots of observational data to support that. And if you have a large goiter or a cold nodule, then it's much more preferable to radioiodine, clearly. Downsides, lifelong thyroxine. However, the doses will be relatively stable compared to thyroxine after radioiodine. Voice and swallowing problems could end up with long-term issues. Hypoparathyroidism, as has been discussed, and a neck scar and a GA. With radioiodine, no surgery, no scar, no GA. Great. So no operation, so that's really a big plus. Negligible side effects. The downsides, it is relatively slow acting. A lot of patients will end up on thyroxine at some stage, and there's a 10 to 15% failure rate. When I say failure rate, that means that they will become hyperthyroid or they remain persistently hyperthyroid after the first dose of radioiodine. Well, and I'm sure my colleagues will argue that, well, you can always give them radioiodine second time, but if they fail second time, it just makes surgery much more challenging and difficult. Radioiodine is contraindicated, obviously, in pregnancy and lactation. My colleagues, at least in Sheffield, are not keen on giving radioiodine to patients with thyroid eye disease, although there's a lot of evidence that suggests that you can give steroids and use radioiodine in patients with mild to moderate eye disease. Large goiter, radioiodine doesn't really do much. There are some reports that it does shrink the goiter from between 30 and 50%, but for very large goiters, that's not enough. So that's another problem. And you have to avoid pregnancy for 6 to 12 months. There are a significant number of patients that we see who are in the mid-30s, who are aiming to start a family or want more children, and when they hear that we shouldn't ideally become pregnant for a year, that's a problem for them. So they express a wish to proceed to surgical treatment. Okay, right. So let's say we come back to this lady and we've made a decision for surgery. So what surgery we're going to do? I'm going to speed up because I don't have much time. So it'll be a total or near total thyroidectomy. And how do you prepare this patient for the operation? I'll come to, this is a slide. So surgery is total or near total thyroidectomy. We don't no longer discuss subtotal thyroidectomy as an option. So I'll skip that. Thyrotoxicosis should be adequately controlled. How do you assess if somebody is toxic? Clinical features, biochemistry. And if they're not well controlled, you get your medical colleagues' help to control it. There are a number of drugs that can be used. Laryngoscopy, we request routine laryngoscopy in all of our patients having thyroidectomy. And like Dr. Khan has already explained, check your calcium profiles, correct your vitamin D deficiency. That will reduce your post-thyroidectomy hypercalcemia rates. Very rarely, calcium is important because very rarely we have seen the occasional patient who's hypercalcemic and they've got primary hyperparathyroidism, and you really don't want to do a total thyroidectomy for Graves and leave behind a parathyroid, enlarged parathyroid gland and have persistent hypercalcemia. So it's a simple test, so ought to be done in all patients prior to thyroid surgery. Right, we come back to our patient. So we planned a total thyroidectomy, normal vocal cords. She is still quite toxic and she's vitamin D deficient. So how do we manage thyroid function tests? We'll talk about vitamin D deficiency. How do you address that? That's easy. You give them a slug of cholecalciferol prior to the operation. Right, there are some people that have started to say that you don't really need to control thyroid functions. You don't need to be too rigid about it, just do the operation. Patients are usually fine, and they have claimed that there is no difference in complications whether you control the thyroid function quite stringently or whether you're a little bit relaxed about it. However, the traditional view has always been that you really have to control hyperthyroidism quite well to avoid thyroid storm. That's what the ATA guidance says as well, that patients should be rendered euthyroid prior to the procedure, and that's what we aim to do as well. So at the very least, free T4 level should be less than 30 and free T3 less than 10 as per our units. That's slightly above the normal range. And there are a number of drugs, I'll show you in the next slide, that we use. So I know we as surgeons don't like to talk about mechanism of actions of drugs, but I think it's a good thing for trainees to understand, get their head around. So this is a slide showing thyroid hormone biosynthesis. You find the iodide ions getting into the thyroid follicular cells. They're oxidized to iodine. The iodine gets trapped onto the thyroglobulin. You get iodotyroxines. The tyrosines are the residues in the thyroglobulin molecule, and the iodotyroxines are the building blocks for your T4 and T3. So you've got the antithyroid drugs. They act on all steps in the thyroid hormone biosynthesis pathway. So they're very effective. You got, oops, sorry. It's not very good, is it? So you've got antithyroid drugs that act on all of the steps in the thyroid hormone biosynthesis pathway. Carbimazole also affects your immunity in Graves. PTU, in addition, stops T4 being converted to T3. Okay, so those are the main antithyroid drugs and their effects. You've got beta blockers that stop T4 to T3 conversion and also inhibit the sympathetic effects, the tachycardia, the sweating, your pulse rate, and your hyperdynamic circulation. You've got cholestyramine that we use quite frequently in poorly controlled Graves. They increase your T3, T4 clearance from your circulation. We've got steroids that affect your immune response in Graves and also stop T4 to T3 conversion, T3 being the active form, so you want to have reduced levels of T3. And you've got Lugol's iodine that blocks the synthesis again. Lots of Lugol's will help control hyperthyroidism, especially in the days leading up to the operation. Okay, so I think I will skip the slide on Lugol's. So this is a protocol that we use for people with uncontrolled disease. So the problem we often have is we say to the endocrinologist, oh, can you get the patient's control and I'll do an operation. And they try and get the patient under control, and the patients lose control, and this can go on and on for quite some time. So what we often do, especially for patients whose T4 levels are over 100, T3 is over 50, we say, fine, this is the date for the operation. Let's aim for that date. Let's control the patient before the operation. And we ensure that all of these patients have Lugol's iodine. I'm a great believer in Lugol's iodine for 10 days prior to the operation. We check their blood 7 days before, and 5 days, 3 days, and 1 day. And then we gradually add these other drugs, including cholestyramine, propranolol, and steroids. And we find that the vast majority of patients can be really well controlled with the combination of these medications. Even those patients who have had neutropenic sepsis with carbimazole, who do not tolerate carbimazole, we can control them with a combination of Lugol's, cholestyramine, beta blockers. So this chart shows a series of 19 patients with really badly controlled Graves, and you find that T4 and T3 levels coming down in the vast majority within 10 days. Okay. Right, vitamin D deficiency, I think we've talked about. We'll leave that be, we'll skip that. Okay, I wanted to highlight on this slide. So counseling patients is really important. You are operating on somebody with a benign problem where there's a very good alternative treatment option, i.e. radioiodine. And essentially, you're competing against a non-surgical treatment where there's no use of general anesthetic and there's no significant complications. So there is a lot of literature that says that Graves surgery, in comparison with non-Graves thyroid surgery, is associated with a higher risk of complications. So patients should understand that there is a good alternative and surgery has got some significant risk. Now, I've put our own data here, and I want to emphasize that hypoparathyroidism is a significant problem. About 5% of our patients were still hypoparathyroid at 6 months. Although in the long term, most people come off their alpha-calcidol and calcium supplements. And the complications should not be compared to other kinds of thyroid surgery. They should be compared to radioiodine, where the complication rates are virtually negligible. So use your local data if available for counseling, and remember that the risk-benefit ratio is smaller than that for cancer surgery, and that there are alternatives. So just a couple of slides on surgery, and then I will stop. Generous incision and exposure is important. If you're struggling, think, should I extend my incision? Should I divide the strap muscles? And should I just use my assistant better, or maybe even get another person to help? And take your time. This is a very amusing cliche by a famous American professor. Before you start thyroidectomies, ask your scrub team to take the clock down and put the calendar up. Yeah? Take your time, essentially. Don't rush. Right, bleeding is often a problem because the gland is obviously extremely vascular. The thyroid gland is one of the most vascular glands in the body per gram of tissue. and Graves particularly is extremely vascular. The problem with the vasculature is not the bleeding. You might bleed 50 ml or 150 ml. That is not an issue. The issue is it discolors your field and it stops you from seeing these parathyroid glands clearly, and sometimes obscures the planes below which the nerve is lurking. So a few tips on controlling bleeding. And you just have to ignore, sometimes your anesthetic colleague might say, what's taking you so long? It's just a small gland. It's not like a big retrosternal goiter, and what's happening? And you've got to keep in mind that it's these small glands in Graves that are more difficult, where you really struggle to preserve the parathyroid glands. And it helps, this picture helps to explain to people when, if you're being criticized for taking your time. So this is a picture of a duplex scan picture of somebody with Graves' disease, and this is called the Thyroid Inferno. The vasculature is so profuse, which kind of explains why you get bleeding. Okay, so I'll keep this to a minimum. So laryngeal nerves, parathyroid glands, those are the important things you want to leave behind. We all know that. With the parathyroids, I'd say, capsular dissection is really important in Graves. You want to preserve this arcade, and that's lying on the capsule. So you want to be capsular, maybe even subcapsular, clipping these vessels as they enter the capsule. I don't use harmonic or ligature. I use the old-fashioned sort of clips, clipping and cutting, particularly because I'm worried about what the harmonic would do to thrombose or clot off these vessels on the capsule. I don't necessarily hunt for the glands. I look out for them, and if I find them, I obviously preserve them. But I don't necessarily insist on identifying all 4 glands. And the other thing I do, especially in Graves, is I do not dissect the nerve all along its length. If I've seen the nerve here or here, I'm happy with that. I don't completely expose the nerve, because there are these vessels from the inferior thyroid artery that run in front of the nerve that you will have to divide if you want to expose the nerve all along, and you will devascularize the inferior gland. You might leave it behind, and very often we leave the glands behind, don't we? We don't always, very rarely we take it out. We do an inadvertent parathyroidectomy, but we're leaving behind ischemic glands. So that's another tip. Post-op care, essentially, the 2 main things, aren't they? One is the airway, the other is hypoparathyroidism. We talked about thyroxine supplementation, so I won't go into that. So with hypoparathyroidism, as long as you have a formal written down protocol, that's all that matters. Your protocol might be different to mine and vice versa, but as long as you have something that you can all agree with in your unit, your juniors, your colleagues, and treat patients consistently the same way, then that's what is most important. So this is our protocol after thyroidectomy. We look at the PTH the first day, look at the calcium, and then we decide to give alpha-calcitrol plus minus Sandocal in patients where there's a problem. So the majority of our patients won't get routine supplementation, but we do make sure that preoperatively they are vitamin D replete. Okay, right. It's also extremely important. We've been talking about this at the BATS, that we all people, everyone practicing thyroid surgery have a clear protocol in the unit for what to do for neck swelling. We've all heard of instances, we've all had instances of dramatic neck hematomas, bleeds, and the most important thing, it's not a problem having a bleed. We all have bleeds from time to time, but having a clear protocol on the early detection and the appropriate management of these bleeds. Every year in England, there is one patient on average that has a catastrophic consequence of a bleed. Hypoxic brain damage, respiratory arrest, and so on. And a lot of the times, it is down to late detection and inappropriate early management. So people in the wards, the junior doctors, the nurses, they have to be educated about this. They have to have a protocol where they know what to do. So we say, sit the patient up, give them 100% oxygen, give them steroids, look at the patient is getting worse. You have to be prepared to open the stitch at the bedside, and people are often very reluctant to do that, and or call for help. So it's important to have this protocol. The Oxford unit have published a video on YouTube. It's called the Scoop video, and we've got a protocol very similar to that that explains to the juniors and the nurses as to what to do. Because the last thing you want is one patient. One patient is sufficient, for your career with a significant bleed that's inadequately managed, that has a arrest before you had the chance to evacuate the hematoma. Okay, patients find surgery, patients are quite satisfied after surgery in comparison with radioiodine. They are more satisfied. I mean, this is not a randomized controlled trial, but our experience is that they are, the vast majority of them are happy that they've had the surgery. Okay, so that's a summary, but if you have any questions, I'll take the questions. I know I'm running late.